Hi, everybody. I'm Simon Lee, and I'm chair of the Department of Population Health and a member of the Cancer Prevention and Control Program. Our guest today is my friend and colleague, Dr. Karen Wernli, who's visiting Lawrence from Seattle, where she is senior scientific investigator at the Kaiser Permanente Washington Health Research Institute and professor at the Kaiser Permanente Tyson School of Medicine in the Department of Health System Science. Dr. Wernli is a cancer epidemiologist and health services researcher whose work focuses on incorporating patient-centered outcomes to improve cancer care from prevention to survivorship. A UC San Diego grad, she completed her master's in epi at UT Health School of Public Health and then the PhD in epi at the University of Washington. She's been active in the American Society for Preventive Oncology, where I get to see her every spring. She currently chairs the ASPO Survivorship and Health Outcomes Comparative Effectiveness Research SIG. She's a longstanding reviewer for the American Cancer Society Health Policy and Health Services portfolio. Her science itself has been supported by the AHRQ, currently the CDC and PCORI, as well as the NCI. In the last few years alone, Dr. Wernli has led studies of comparing mammography to MRI for breast cancer surveillance and examining temporal trends and geographic variation among receipt of medical and surgical and pharmacological interventions among AYA cancer patients. I'd like to note that in the cancer care delivery research space, she's the CCDR lead for Kaiser Permanente's 66-site NCORP network. Drawing on her current R01, I'm really excited because this work that she's going to talk about today reflects a type 2 hybrid comparative effectiveness implementation study design that is both pragmatic and randomized and uses mixed methods in its evaluation. So she's hit all of the points of the kind of research that I like to do. And it's a really great honor to have her here today. Dr. Wernli, thanks for joining us.
Thanks very much, Dr. Lee, for that great introduction. It is a great pleasure to be here because I'm here for a family event. And so being in Lawrence and actually at the University of Kansas goes back to family roots and is a great honor and privilege to be able to speak here today. The title of my presentation is around multi-level interventions for lung cancer screening, innovations and lessons that we've already learned. I'm hoping that through my talk, I can highlight I think that's better. Some of the work we've been doing at Kaiser Permanente Washington in intervention development, patient-centered outcomes, stakeholder engagement in the development of this research project, also highlighting how we've learned these lessons from other cancer sites. I should say, Ashley is monitoring the chat, right? So if people have questions throughout the discussion and you're online, please put them in the chat. And for the people who are in the room, if you guys have questions, you can answer, just raise your hand during the presentation. I'm happy to talk most of the time, and then we can open up for discussion later. Or if you have imminent questions during the presentation, we can have that kind of conversation too. I'm open to whatever works for everybody.
I will take that white.
Thank you. I'm like, which one? There we go. I've started my presentations with images like this. And I want you to sort of think about, what do these images mean to you when you're thinking about when you might have seen these or reflect on these? I do this because when you're focusing on lung cancer screening, these were sort of the images of my childhood of public health campaigns to reduce tobacco use in the United States. And these images, plus other public policy interventions, were really effective in reducing the prevalence of tobacco use from like 1/4 of the population to like 12 to 15% in many areas today. But these types of images also continue to stigmatize the population who consumes tobacco. And I think it's really important for us to really center, when we're talking about lung cancer screening, how we ourselves bring our own biases into these spaces, and to think about that as we move forward in researching these topics. Lung cancer is the leading cause of cancer mortality and results in more deaths every year than all the other cancers that we screen for. And the reason for this is that lung cancer most commonly is diagnosed at late stage, where treatment is no longer as effective as it is for early stage cancers. We have had screening tests for breast, cervical, and colorectal as part of national policy for decades. And it's really only been in the last 10 years that we have any screening test that's available in order to find lung cancer earlier. You know, in the 70s and 80s, there were a lot of studies that were trying to see whether or not you could give somebody a chest CT, or not a chest CT, sorry, I've already skipped ahead, a chest x-ray to see if they could find nodules earlier. And sometimes that was paired with sputum samples, but all of those trials were ineffective. And it really hasn't been until several large national and international trials were done in order to compare low-dose CT, which is CT tests at a lower dose, in order to find nodules for cancer earlier, to reduce mortality from lung cancer. And so now, national policy in the United States is to offer US adults who are between the ages of 50 and 80 years a low-dose CT to find lung cancer early as a screening policy. And these is available for everybody who has a 20-pack years tobacco use history, who is either a current smoker or have quit in the last 15 years. The US Preventive Services Task Force, this is their statement from 2021, expanded criteria at that time. And now there are about 15 million US adults who would be eligible for lung cancer screening in the US. If you do any work in lung cancer screening, you know that uptake is really low. But we're going to put that in a parking lot, and that is not what I'm talking about today. What I'm talking about today is the continued participation in cancer screening. It's recommended that people who are eligible for lung cancer screening be screened every year, but the population level benefit of lung cancer screening is really not being achieved because annual adherence rates are currently too low. A recent systematic review calculated with a meta-analysis the annual adherence for those who have normal findings. So these are people who have a lung RADS assessment, that's the radiology assessment of a 1 or a 2, is less than 50%. So that means that less than 50% of those who screen normal are not coming back within a year to get their next test. And it's really important that people come back every year because in the clinical trials, most of the lung cancers are actually detected not on that first scan. You know, the first scan that people receive is really their baseline scan, and that's detecting prevalent lung cancer. It's the continued participation in screening that allows you to detect incident cancer and find nodules where they might be treatable. And the nodules that are detected on these subsequent scans have a higher probability of being cancer. The modeling studies usually presume that adherence is at 100%. In clinical trials, it was close to 90%. Given that that's not what we see in community practice, then the benefit of screening at current adherence rates is like half as to what it would be in the clinical trials. Several studies have shown that lung cancer screening programs with a population health management component, I call this, that's what I call it, they call it centralized cancer screening programs, tend to achieve the highest rates. And what that really means is not just that you've built system supports, but also somebody sort of paying attention as to whether or not people are doing the things that they're supposed to be doing. That same systematic review concluded with patient adherence to lung RADS recommended screening intervals is suboptimal across clinical lung cancer screening programs in the United States, and that this is especially true among patients with results of the lung RADS categories 1 or 2, so these normal findings. And sort of this is where my research comes together. I'm really interested in these gaps that have been created in lung cancer screening, particularly in a place that most people are falling. About 85% of people who screen will have normal findings, where it's also a place that is important to the clinical care delivery system and has the biggest impact on population health. So some of my pilot work, we started by convening a patient advisory board. I work at Kaiser Permanente, Washington, which is both a health insurer and healthcare provider in the Pacific Northwest. We have clinics with primary care and specialty care sort of within the Seattle metropolitan region, but down to our capital, which is about 60 miles south, and then over on the Olympic Peninsula, which you can either reach by ferry, which takes about an hour, or you can drive to, which also takes a little over an hour. And so I actually met with patients who live more than an hour away from where I live, where I got to by ferry, because I was really interested to understand their experience specifically. I've noticed that a lot of our care processes are developed for people in urban areas, and I wanted to really understand sort of what they were going through. And so in convening this group, we started talking about what actually influences annual adherence. And we just started putting up what people were saying. And then we started to sort of group like things together, things that sort of fit together. And using that, we then did this, what we call this big sky ideation. This is where you start to think about what could be possible? If we have these problems, what is even possible? And you try not to limit sort of direction or scope or resources and just let people come up with any ideas that they had. And then we used those ideas to come up with scenarios that we gave to patients and asked them to sort of draw out in these storyboards, what are some new ways that we could improve annual adherence to lung cancer screening? This is sort of one of these depictions, and you can see sort of what an individual has done, and then also our own assessments in the blue notes. But we then use those stories in order to think about what the messaging content should be and how to encourage annual adherence. And that's a photo of us meeting in one of the local clinics, or not a clinic, community center. That's been a lot of fun. And patients had really clear ideas about how to improve annual adherence. We talked about how they didn't know that they were supposed to come back every year. So they might have gone through a shared decision-making conversation, or they would have with their primary care doctor. But in that conversation, they didn't really talk about annual adherence or normalization of lung cancer screening, or that coming back every year was going to be important. They talked about how patients needed more knowledge about what the tests were and how to follow up. Again, sort of related to like the normalization of lung cancer screening. They didn't see lung cancer screening as being a part of other population health programs that we have for cancer screening, just like for breast or colorectal cancer. They want us to improve access and convenience through different locations and convenience in scheduling of scans. Many of our radiology practices now offer sort of not just business hours for imaging, it's on the weekend or even later in the evening. And they also suggested that we provide financial and non-financial incentives for completing subsequent low CT scans. This is all what the patient said, but we also talked with a lot of clinical and operational leaders to ask them what they saw as what the gaps were. I think we talked to like 15 different stakeholders. These are people who were, what would their roles be? You know, like quality in primary care, the pulmonologist, a person who's in charge of like cancer prevention screening, all of these individuals across our organization. And they also had really clear ideas about how to improve annual adherence. They said that there was confusion about who was responsible for what and when. And so being able to clarify roles and responsibilities for lung cancer screening were really important. When we first initiated screening in our healthcare system, a significant proportion of low-dose CT scans were actually being ordered by pulmonology, and over time that's shifted to primary care. So understanding when primary care can manage it and when it needs to be referred to pulmonology was really important. And that sort of speaks to being able to enhance care coordination across primary care and specialty care, because those two entities really need to come together. We heard that clinicians and the staff needed more training in lung cancer screening. The trial that I'm going to describe to you was initially designed to be a cluster randomized trial. We couldn't actually cluster either at the clinic level or the physician level because there's just so much variation in the number of patients who are actually eligible for screening. Some people have very few, some people have a lot, and because there's such heterogeneity, you can't really create clusters that were really comparable. And what that means is that the local sites themselves and the physicians themselves don't necessarily have a lot of experience in offering lung cancer screening in their individual practice. They talked about automating our electronic health record tools to ease clinician burden. When we enrolled lung cancer screening at our site, we had built some smart phrases and smart sheets that prompted the order for the low-dose CT, but the physicians found that to be really complicated. And even though there's a population health management alert for when people are eligible, you only see that if the patient is sitting right in front of you. It doesn't actually have population health management features to allow people to know, oh, here's a group of people who are due for lung cancer screening. And then the last thing was just generating data metrics for clinical benchmarking because nobody had the data. When I ran the analysis to see the proportion of people who had normal findings, how many of them were adherent to on-time screening according to clinical guidelines, in my system, it was close to like 28 to 33%, about a third, which is similar to what we've been seeing in other sites. I just wanted to show you the storyboards because this was a really fun activity. And if people ever get a chance to do this, I highly recommend it. It sort of shocked patients when they were doing it, but it was really interesting to see sort of what people drew, how they drew it, and how they approached solving problems. And I wanted to highlight that because the last thing is we tried to understand what were the design features of interventions that we might deploy that would improve effectiveness of those interventions. And I think there are 10 on this slide. I think there are 10 features. But you can see things like having it be individualized, having it speak to their feelings, having them feel like there's sort of shared responsibility. This all comes from the patient's perspective, not from the stakeholder perspective, but really relates back to what might be effective in building that trust in those relationships. I wanted to highlight social support. I mentioned this to Simon earlier when we met. We were all on our research team really surprised to see that social support was a key feature and consistent across many of the storyboards that the patients came up with, because it really was not something that we had thought about earlier. When I did this pilot work, I was totally agnostic to intervention development. I didn't really come in with an idea as to what I wanted to test or how I would test it or what the gaps were. And I feel like being able to let your data tell you the direction you need to go also allows you to see a path that might be most effective. So I've explained some of the gaps that we're currently seeing in adherence. I've talked to you about some of the barriers and potential solutions. But this isn't rocket science. We've been doing cancer screening prevention work for decades. And there's a lot of work that's already been published in breast, colorectal, cervical, prostate cancer screening to tell us which direction to go in. And what this body of evidence tells us is that these effective strategies are usually around multimedia interventions that can provide educational content to promote screening behavior and patient and provider directed reminders. These are the two most effective ways and most impactful, consistent to improve rates of annual adherence. And these are aligned with the barriers that we defined from our patients. This is what they said would be helpful for them as well. You can see that some of the key benefits of multimedia interventions is I don't know how long everybody's been in research, but remember how we used to like send CDs or DVDs to people in the mail so they could like watch them on their home machines. You know, sometimes it's been sent to clinicians as well. You know, it doesn't take a lot of resources to do that. You can retain fidelity of the messaging. You can send it multimodal. We could have sent things like in a pamphlet or in a DVD or now in online videos. And it's really most impactful in improving short-term knowledge. For patient-directed reminders, these just need to be appropriately timed in order to meet the healthcare need. They also can be multimodal. You can step them in intensity, like the number of reminders you choose, or whether or not somebody, sort of gets escalated. And that can really be dependent on the available resources that you have to you. And then I just want to come back to this image again, which is when you're thinking about what these interventions look like, to always then reflect particularly on, in this case, people who are high users of tobacco. In all of my work in cancer screening, for a long time, I've been doing this for like 25 years. I've heard people say, people who smoke, they don't get screened. People who smoke don't come back. And I think when you're thinking about trying to encourage people to come back, it's important to sort of center this here. Is this what the healthcare system has created for their space, or is this what the patients are choosing? We just need to be able to open the doors for people to feel welcome. So I'm currently leading a type 2 hybrid effectiveness implementation study, where our specific aims are compare the effectiveness of two multi-level approaches relative to usual care and improving the rates of adherence to national clinical guidelines for lung cancer screening. Also to improve patient-centered outcomes and clinic-level outcomes. I'll share a little bit more about what those outcomes look like. And then also to determine the patient, clinician, and system-level factors that influence changes in adherence to inform lung cancer screening programs. Well, we have developed these interventions at KP Washington and are testing them at KP Washington. I really want these to be scalable interventions and things that people could adopt or adapt within their own local setting, because there isn't anything here that's really specific to KP Washington patients or necessarily to people who have access to healthcare or health insurance. These are gaps that we see in lots of different healthcare systems that need to be closed. The two interventions that we're testing, the first is what I call a patient voices video. And the purpose of the video is to provide additional educational lung cancer screening that goes beyond shared decision-making. I never want to touch what the communication between a doctor and a provider in their intimate encounter. I just don't want to be a part of that, and I don't want to change the behavior. But given what I heard from patients and sort of what I understand, I know that patients need some additional information that normalizes lung cancer screening, reminds them when they're due to come back, and also encourages support through family and friends to help support them to get there. And we deliver this intervention near the time of their negative test, sort of the index scan, this lung cancer screening test that sort of gets people into our trial. You'll see I have a little figure about it. Like 2 to 3 weeks later, we're delivering this intervention to them. The second intervention is what I call stepped reminders, because it has increasing intensity of touches. And it reminds both the clinician and the patient when they're due for repeat screening. So we are pending orders to the PCP for them to sign for our screening lung cancer test. And once that order is signed, then we are sending reminders directly out to patients to get them to schedule the test. And if people don't respond to sort of the passive communication that they receive, our nurse will follow up with the individual if they don't schedule. And this is delivered really close to the time in which they're due. When you talk to a lot of people about reimbursement, particularly from Medicare, you can't get a screening test unless 12 months have elapsed. So it really needs to be due or sent very close to the time in which people are due, because they wouldn't be able to schedule and have their scan be reimbursed. This is the study flow of identification, randomization, intervention delivery, and timing. We're using our electronic health record in order to identify a cohort of people who've been screened for lung cancer. We have minimal restrictions, although one of the restrictions is that they do have to be within our KP Washington system. Some people get more of their care outside our system than internally. And so that's probably the biggest exclusion criteria. So that allows us to actually be able to see what's happening in people's health records. They are then randomized in a block randomization, and this block randomization is based on whether or not it's their first low-dose CT or they've had prior screening, and then also based on tobacco use, so whether they're a current or former smoker. You can see the top line is what happens in usual care. So people can continue to get orders from their provider if they go in for a well care visit or some other visit. We've recently been talking about how some people will actually get chest CTs during the course of follow-up because of changes in health status or concern or for some other reason. In the middle bars, those are people who are both are randomized to the patient voices video. And so you can see that that comes really close to the time after their qualifying test. And then the last bar, people who get the stepped reminders. We're doing a survey of everybody across all the 4 arms about 6 weeks after that qualifying low-dose CT, and asked a variety of patient-reported outcomes around health beliefs, their knowledge of lung cancer screening. This is one of the few places we're actually asking people directly if they received the videos, if they remember receiving the video. There are a few other things on that survey. And then you can see, oh, this shit's wrong. 8 weeks prior to the next, it's actually now 4 weeks prior to the next low-dose CT is when we actually initiate the next ordering for the patient to try and get them back in. We will measure adherence rates within 9 to 15 months to look for the next low-dose CT. And we are also doing participant interviews and stakeholder interviews after people have passed sort of our observation window. And we'll be doing interviews across all arms of people's experiences with the interventions. We just launched, I think that's what this one is. Oh, no, it's about the video. So before we get ready to go through a little bit more details, I'll show you the video. I worked with a local design firm based in Seattle. I worked with them on some other interventions before. I don't know if people have ever worked with a design firm or if you have artistic or design skills yourself. This is not really my strength. But what I love about partnering with other people is that you can be really smart. We just talked about this in your own way, and then work with other people who are also really smart in their own way. So I'm gonna back it up. This is our patient voices video.
Way to go! You just made a great step to care for your health. You recently completed a lung scan to take an image of your lungs. This is the only test that is available to find lung cancer early. Did you know that lung cancer screening at Kaiser Permanente is part of a long-term health program? It's just like the health programs we offer to find breast and colon cancer early. Participating in a lung cancer screening program is an important step to care for your health. As you know, lung cancer screening is offered to adults who are between 50 and 80 years old who currently smoke or who smoked in the last 15 years and have a history of tobacco use. Patients have told us that they did not realize it was recommended to get another lung scan even if you had normal results the first time. One patient said, "I am really glad that I decided to come back after the first lung scan because it feels like I'm doing something for my own health. It also makes my family feel better." Do you know how often people are asked to return for another lung scan even with normal results? Based on your most recent results, you should get your next lung scan with a low-dose CT in 12 months. Coming back helps your care team keep tabs on the health of your lungs by noting any changes from scan to scan. Although most people will come back once every year, one patient said, "I would not have known to go back every year. Returning to lung screening has turned out to be very important to me. My first scan showed nothing. When I had my repeat scan in December, it showed several nodules in my lungs. Because of this, it prompted my doctor to order more imaging. I have an appointment next week with a specialist. Some patients report that talking with their family members and loved ones help them feel supported in taking actions related to their health. Your doctor is also a great resource to talk with and can be a partner in helping you decide which actions are most appropriate for you. Looking for lung cancer can seem scary. It might make you feel nervous about the scan, especially because of your smoking history. However, finding cancer early is important to your long-term health. Taking care of yourself through a regular cancer screening program might help you feel more prepared in knowing that you can do something positive for yourself. Before you can return for a lung scan, your doctor will need to order one for you. You should hear from your doctor's office when it is time to schedule your next scan in about 12 months. If you don't hear from them, please follow up directly with your doctor. Take care, and we'll see you soon.
You get to hear. That was so much fun. I built the prototypes. I worked with some team members locally, but they were able to sort of take it and finalize the product, and they did it essentially in 2 weeks. It took a little bit longer than that because we sort of tested the penultimate version, but from beginning to end, sort of the majority of the content, when you work with people where that's like all they're doing, they can do it in 2 weeks. It's incredible. Our intervention delivery is facilitated by this electronic health record workbench. We have an Epic-based electronic health record. So it's a population health management tool that allows the screening coordinator that we've hired in order to actually deliver the interventions. We have currently only launched the patient voices video. We haven't made it to stepped reminders, and releasing the video is sort of the simplest of the interventions. As you can imagine with the stepped reminders, people are in many different spots along the way. Did you just mail something? Did you send it? Like where are you at? But it allows us to facilitate communication that goes both through the patient portal. So for all the interventions, the first mode of contact for most patients is through their patient portal. About 80% of the people in our patient voices video are on the portal. And that's where they'll be receiving their first message. But the follow-up communications and the reminders are all sent through the mail. But it also allows us to order low-dose CTs and send that to the primary care physician through the workbench. And then the lung cancer screening coordinator is a medical assistant that is funded by the research study, but she's embedded in the clinical care delivery side. And she's based in population health, works within a population health structure. It's very similar to other mechanisms we've established for cancer screening. And she's the one that's responsible for these communications. This isn't my study, but I wanted to highlight how we've built these swim lane diagrams of clinical workflow. And I recently found this paper that I thought was beautiful. So I put those highlights in here because I don't have these images yet. I have a very messy, not messy, it just is like over many sheets and it's complicated. And if I showed it to you, it wouldn't look cute like this. And this is what we're going to have to build, is something that has our team. But the amount of work it's taken to understand the clinical workflow, I thought I knew everything. And then we started talking about, well, when is Medicare going to reimburse you? And you're like, I haven't thought about that. That even though you think you know everything, that there are details about this that you still don't understand. And it's really in building these swim lanes that you see this. And this is also not from my study, but these are also examples of sort of what it starts to look like in Epic in terms of how you're managing patient flow. We have actually on our team an Epic analyst who sits within the research world, who's building these components, but she directly connects with people in the clinical care delivery to make sure that everything that we build is aligned with KP practices. what is really hard about Epic builds is if I build it in my system, I cannot share it with you because it doesn't fit. It only fits in my Epic. And it's not because we didn't build it right. It's because anything you do build only fits. It's so specialized. It only fits in your own Epic. But I think trying to figure out how to simplify it or make things accessible across systems is really important for multi-level interventions. So we really did just launch. I think we're in wave 24, 25. Every week, our study programmer is identifying people who just had a load of CT 2 to 3 weeks prior. And that's when the randomization happens. It populates into this Epic workbench. It populates into our survey. And all those individuals we know already at the beginning are randomized, and we're starting to follow people. It's 2x2 factorial design, which means we're able in the analysis to collapse across categories. So we can compare patient versus video, which is people who only got the video or people who also got the stepped reminders, to people who did not, and the same across the stepped reminders. And then we have, 2x2 analysis of that, so we can see the actual direct impact of both of those interventions. It is a pragmatic clinical trial, which means while I have a protocol, nothing necessarily happens the way that I wrote it because things will change. I'm in a very fortunate place to be where I have a lot of clinical engagement and people are very supportive of my research program that allows me to remove barriers that might be impasses for other research studies. And I think it's because, as I showed, like Mind the Gap, people see how big that gulf is. It's not just a gap, it's the Grand Canyon. And we're trying to make it much, much smaller and more effective. We had planned to be enrolling 2,200 participants per week, but we're actually seeing that the clinical delivery system is doing more scans than I had anticipated. They've continued to do more scans every year that we've had the program. So we're actually ahead of schedule by several weeks to months, and are thinking that we will continue to enroll during the duration of the study as we had planned, but that will allow us to enroll more people than we anticipated. We'll have at least a sample of 1,606 people within 2 years, and that's what the analysis is powered on. These are the measures that we have across the healthcare system, the clinic and the clinician and the patient. And we are using electronic health record data, patient-reported outcome survey, qualitative interview data. I should have said we're also using sort of metrics that are associated with the workbench, which also come from the electronic health record, but are sort of process measures, as well as from the Vimeo site where our patient voices video is hosted. You can see that a lot of these are things that we would normally anticipate, like rate of annual adherence across the arms, as well as like the number of orders that were placed or the number of steps that the coordinator needs to go through in order to get somebody to schedule a low-dose CT when we need to. Our study population that's been enrolled to date or in the study is balanced on sex, age, tobacco use, and prior cancer screening history for lung cancer, but is primarily a non-Hispanic white population. I've inquired within my own delivery system at KP Washington in that region, in our region, about 70% of our enrolled participants are non-Hispanic white. And what I think might be happening is that physicians are underestimating the prevalence or use of tobacco in patients of color and not presenting them with lung cancer screening as an option for them because they don't perceive them to be eligible. We are hoping, because that's not part of my trial, that maybe to work with the delivery system to see if we can expand scope and sort of change who actually gets a first scan, because it's at that first scan that people would be eligible for the study. And then I wanted to share some of the things we've learned from our patient voices video delivery so far, particularly through the success of the patient portal. I've never done anything in a patient portal before, and I've been blown away as to how successful it can be. So as I shared, about 80% are registered on the portal, which means 20% do not have patient portal access. That among those who are randomized to the video and have access to the portal, 70%, 71% are actually opening the message that they get through the patient portal. And when they do open it, most of them are opening it, 84% are opening it within a day. You actually see like a lot of zeros or like 0.1, which means people essentially get a text message on their phone that there's a new message in their portal and they're going to their site to open it right away. Yeah.
Okay, so procedural question. So anyone who's received a scan is eligible?
Yeah.
And they're invited to participate. What's the rate of refusal or just not enrolling? Or are they automatically enrolled?
They're all enrolled.
So how do you consent them?
They're not consented. It's part of standard of care.
It's part of, okay, that helps. So of all the people who have had a screening, they automatically are in the study. They're
Yes.
randomized.
Yes.
Okay.
The way that we have a waiver of consent for participation because it's low risk. And a waiver of, what's the other waiver? The waiver to identify people, of HIPAA, so that they can get into the study. Everybody is invited to the survey. So at the time of the survey, we send a notification about the research study. And it says something like, Kaiser Washington is testing different ways to improve communication around lung cancer screening. We want to do this survey. You might get some other things. It's a little vague. And when you look at, they're called Zelen pragmatic trials as a way to enroll people in low risk healthcare system interventions. And then dispense information so that they understand it's a disclosure statement that they're in a part of a research study. But the delivery of the interventions and the primary outcome, which I can measure on the electronic health record, are set and approved by the IRB without direct consent.
So I noticed in your awesome video, which I really loved, that you probably mindfully made sure that you are representing a lot of different types of people, different ages, races, different sort of like implied living situations or that sort of thing, which I liked. Are there opportunities for people for whom English is not their first language to receive the video in Spanish or I'm not sure what the most common Asian languages are in your area? Is that available?
We did translate the video into Spanish, so it is available in Spanish subtitles, but we don't have Spanish audio. And it's also my understanding that it would be available as closed captioning in English or in Spanish if people needed it that way as well. We have talked a lot about other languages and our ability to bring on other languages, and we don't have the capacity to do that right now, but I think it's really important because Spanish is the most common second language within the KP Washington population. It may not necessarily be the most common second language among people who are eligible for lung cancer screening, and it's something we couldn't figure out before we started the study. Yeah.
That's awesome. That's good that you're thinking about those things and looking for opportunities for that. Would the same be true in terms of, is all the follow-up pulled from the system, or is there any additional assessment from researchers so that you could potentially get information that's not necessarily in the patient portal, like socioeconomic factors that might not be captured in the patient portal or social support family factors that might not
Those
be?
all come on our patient reported outcomes survey. There are questions about living situation and social support, questions around education, income, maybe sort of like general housing questions. We're now linking geocoding patients' addresses and then linking to census variables like ADI, which we can incorporate in the analysis. And then we haven't started the interviews yet. You know, we have a way in which we described it in the grant that things have changed a little bit. So we haven't quite figured out exactly what we're going to do, but you know, in a year, I'll have a better understanding as to what that is. But sort of recruiting a population that will be doing the interviews, and there'll be 40 interviews. It's like there's like 2 slides left, I think. I wanted to say, we don't directly link people watching a video to an individual. I don't know that. They don't have individual links. They all go to the same link. And so what we get from Vimeo are these business statistics, like whether or not people make an impression, which lands on the page, or watch the video, and then how long they watch the video, like the average minutes or something, average amount of time. Our initial metrics of viewership indicate that there are about 43 views per 100 people who are randomized to the video, which seems to be pretty high. When I built the video, I was like, I don't know, maybe 8 people will watch it. I should say that the messaging that's in the video is the same that's in the communication. So when we send the patient portal message or the reminder, it says the same thing. You're part of a lung cancer screening program, come back in 12 months. You might connect with your friends and family about this. So people are getting the messaging, even though it may not be delivered directly through the video. I want to just center this back. Currently, there are no HEDIS metrics for any healthcare system to follow, but these are coming. It's anticipated to launch like in 2025, and they're currently being built by AHRQ. And I do think that this is part of a revolution as to what's going to happen in lung cancer screening moving forward, because as soon as you get paid for quality, you want to do quality work. And that's where everything that I've built will be really important for other systems to adapt and adopt and moving forward in lung cancer screening. So I actually think that's it. Other questions online or in the room?
That was great. You've probably thought of this, but I was just thinking about how your medical assistant that's in the population health space, is there any risk that that person being there could create some contamination across your groups just by their presence in that environment, sort of raising a little bit of more awareness around lung cancer screening? Or have you tried to sort of, you know, hide what that person's doing sitting there in that clinical care environment?
Yeah, currently she works from home.
Okay, there you go. She's hidden.
And part of her job is to do other work for bone health, to try and get people to do DEXA scans. And what we've tried to do, it's still being built, the Epic workbench for the stepped reminders, because those people are sort of already exist. Like they're already in Epic. They just haven't been filtered into a place yet. That she won't be able to tell whether or not she'd actually sent a video reminder to anybody. Because that's where the contamination could occur, is if there's anybody who she'd sent a video to that she might then be in contact with again. And it will be distinct because it tells her what to do. It tells her when to do it. And it doesn't give her that prior information to inform any of her decisions. She does, like for the stepped reminders, we have to account for if somebody died, if they developed lung cancer, if they've had a diagnostic CT and disenrollment from the healthcare system. So those are clear indicators that we won't send the intervention to the participant.
We have a question online. Dr. Richter says, outstanding presentation. Love so much about your trial, how it's embedded into clinical practice. I've used Zielinski design to test opt-out tobacco treatment. Mammography has faced and tried to overcome similar barriers to rescreening. How does what you are testing relate to that field of research?
Yeah, I haven't ever tested interventions. Well, that's not true. I've done a chemo prevention trial. A lot of my work in breast cancer screening and with Simon and colorectal cancer screening has mostly been observational studies. But the citation that I cited earlier in the presentation was really around standard effective interventions across cancer screening types. And so while I'm not directly aware of all the types of interventions that have been tested for mammography or other cancer sites, I know that sort of knowledge in some way, improving knowledge and reminders. Anybody who's ever had a mammogram knows that radiology practices have figured out that this is their bread and butter. And as soon as a woman comes in for a mammogram, they are booked. They know exactly when they need to come back, and they are sending letters and trying to get them scheduled. So paying attention to when people need to come back is part of a business practice.
Okay, so you mentioned that I think 83% of your enrolled participants are non-Hispanic white. Do you have a sense of how many participants of other racial ethnic groups are eligible for lung cancer screening within your record? And can you find that? I mean, my guess is because you're enrolling people who have completed their first screening, but I'm wondering if there is a bias in who's eligible and who's being referred. And can you get at that by looking at who is eligible by race and ethnicity?
I mean, theoretically, yes, with IRB permission and some additional funding, but because that's not part of my research goal and I don't have IRB approval, the answer is no. I can't exactly look at that, but I believe that that is true.
Yeah, I mean, two of us here, well, actually several of us here, our work is predominantly in racial and ethnic minority communities. And so this, I mean, provider bias, I think, in identification and referral is a real problem. And it would be, we don't have access to data like this. It would be great if someone could publish something related to this. And I think you're in a great place to do so. But I totally understand that you don't have the funding.
Maybe if I can get a graduate student who wants to take this on as their dissertation and then, just do it, right? I know these are adorable.
Aren't they great? You can throw something at your chair, which I know people love to do. Karen, this is really great. One of the questions, I had a couple of sort of to-do questions that might sort of spin off some conversation. So anticipating sort of your next randomization, your intervention phases, arms. One of the challenges we had, you mentioned the 12-month eligibility lapse.
Yeah.
And part of the problem for us in timing was that the system was never clear, nor were the providers, on whether it was 12 months from the time of LDCT order or 12 months from the time of the actual completion of the scan. And we really ran afoul of that in trying to pull, not just how we pulled the data and thought about it for analyzing, but how frustrated providers got if they were reminded to do something that the system wouldn't let them pend an order. And can you talk a little bit about, you had said that part of your follow-up is that you can pend for the next one as part of the priming of the physician. So it sounds like you might have already thought through what that's going to look like.
We had a lot of discussions around this because reviewers said that when I initially submitted the proposal that we weren't starting the process early enough. And then when we wanted to actually work it out, the providers were like, you're starting too early because we won't be able to put an order in and the patient's going to be hit with a bill. And we don't want them to have a bill because they've gotten a scan at 11 months and 20 days instead of 12 months and 1 day. We are taking 12 months to be from the 12 months of the time of the scan until the next scan, 365 days. And that will be the time in which people are due and eligible to get the next scan. Like, what else was in that question that you asked? In that way, let's say that they maybe have seen their physician for a well care visit because it was ordered, right? 3 weeks prior to the last time. That could still happen, right? That could even happen in our intervention arms. And we're just providing this extra assistance to sort of get people over the hump for people who might not be in that phase.
Does the second, do they also need to do, is the shared decision-making still required for the adherence? It can just
No.
happen. So
It
it's
can
just
just
at the initial scan.
Just at the initial scan. Yeah. So you can bypass additional shared decision-making.
Which means it doesn't have, so then the order doesn't really necessarily have to be tied to an actual visit,
That's right.
right?
As you can imagine, there's a lot of people who might be having Medicare wellness visits. Kaiser's big on prevention, so it often could be tied to that. But you're also talking about an older, sicker population, so there might be lots of other reasons that people are coming in.
You're gonna have really cool data. Do you have a sense of just from your workbench process metrics, what your average time between order and then time to completion of a scan is? Like, is there a bottleneck? Is there any way to look at some of that?
We could look at that. It's my understanding that when the order gets placed, it triggers radiology. Radiology reaches out both with a letter and a phone call in order to schedule people, but they do it one time. And so that might be a place where there's a bottleneck because the order might be there. People might be contacted, but you contact them at the wrong time. And because there isn't any follow-up, it just falls apart.
Yeah.
Yeah.
Because the data we just published and have one under review from our work in Dallas was that the biggest problem we had was not patient completion. And we knew that our navigation arm was more effective. The problem was the physician's inability to order in a timely manner. And I don't think that was the physician problem. I think it was an epic timing problem.
I am so interested in this because I don't know how many physicians are actually going to sign the order that we send them. There might be really good reasons for that, and I hope that they will tell us why. Patient's too sick.
Yeah.
They just had another test and we missed it, right? Like really good reasons. But I'm also curious as to the proportion that might not sign the order at all. And we're giving the physicians a really short window to do it. Our clinical champion has said, if they don't sign it within 2 days and you remind them and they don't sign it, it's gone. They're never going to sign it. So that measure, I think it's going to be really interesting to see what proportion get a signed order.
One thing to think about, because it's pragmatic and you have the relationship with your clinical leads, is you might want to think about whether at some point in your trial, you might start whether you could have standing orders, because it's guideline based.
Yeah.
They have prior evidence that they were eligible and that the provider had decided it was appropriate, and so had the patient. And then what you're basically doing is an opt-out for the providers. They
Right.
get a 2-day window to say, no, not this patient because,
Yeah.
but everybody else, they could just let it go. And that the providers might really like, which would also be really interesting.
Yeah.
That could be cool.
That would be really cool.
Great study. Anything else online, Ashley?
No more questions online.
Thank you,
Ashley.
everybody.
Thank you.